Good afternoon, everybody, and welcome to session 261 of the ThyCa conference. I'm Patty, ThyCa volunteer. The session is on targeted therapies for advanced thyroid cancers, patient expectations. Dr. Brian Haugen will take us through an overview of thyroid cancer care as it's evolved with new approved therapies in clinical trials and on the horizon, as well as future therapies in development. Dr. Haugen is an endocrinologist at University of Colorado Health Sciences Center in Denver, Colorado. He's a professor of medicine pathology, as well as head of the Division of Endocrinology, Metabolism and Diabetes, and chair of the Endocrine Neoplasms Research. Dr. Haugen's clinical and research interests focus on thyroid cancer, including molecular therapeutic targets. Specific areas of research include nuclear hormone receptors and kinase signaling pathways as therapeutic targets in thyroid cancer, as well as proteomic approaches to molecular markers of thyroid neoplasms. Thank you, Dr. Haugen. Welcome.
Thank you, Patty. And I'd like to thank the Thyroid Cancer Survivors Group and Association for the great work that's being done here in advocacy and education, and for inviting me to come talk to you. And again, for this session, what I'm going to talk to you a bit about is the targeted therapies, that basically what they are, how good are they, and again, as Patty said, what the future sort of holds for this. Since I am a physician scientist, I treat patients. So I just want to first show you a couple patient stories. One is a young man who was, he was a teenager when I first saw him about 20 years ago. And he was treated with one of our first targeted therapies, radioactive iodine. And I think many people know about, obviously, radioactive iodine. He had his surgery, had a big tumor, had a bunch of big lymph nodes, and then when we gave him radioactive iodine, this is his picture after we gave him radioactive iodine. Here on the left in the front, here on the right from the back. So we'll focus just mainly on the left. You see all these spots up here. These are lymph nodes in his neck still and upper chest. And these two big areas here is uptake in his lungs. He had lung metastases. And so the radioactive iodine went where the thyroid cancer was. And he was actually very successfully treated with 2 doses of radioactive iodine and is now what we call an excellent response 20 years later and doing very well. So this was really our first targeted therapy. This is a woman who was in her 40s who also saw me probably 25 years ago. And she got treated with radioactive iodine as well. You don't see uptake in that same area you see in the young man. She just has some uptake in her gut, in her bladder, and maybe a little bit up around her salivary glands, but no other uptake. So why did we give her a big dose of radioactive iodine? This is her CAT scan that had a whole bunch of tumors in the lungs. That's what all these big white spots are here in her black lungs on a CAT scan. And so she had what we call radioiodine refractory thyroid cancer. It just didn't respond, didn't take up radioiodine, didn't respond to it. This is what we're going to be talking about today. People who don't respond to this. And I'd like to kind of start with that you really do need a focused team to help them take care of these patients. I believe you need it for all patients with thyroid cancer, but especially for these patients where radioactive iodine is not a good option anymore. And so we have this thyroid tumor program I just list here as T3. And of course, at the center of this program are the patients and their families. This is really our focus. And at our institution, I'll put in a shameless plug on this slide for our institution. We have a patient care coordinator who's dedicated to these patients and their families. Folks, if any of the folks who are on here come from Colorado, they know this is Bev McLaughlin. She's a patient care coordinator and really is part of that center with the patients and their families. And of course, me being an endocrinologist, I think of endocrinologists next. And this is a group of adult endocrinologists that we have. So I'm really fortunate to work with at least 7 other adult endocrinologists who focus on helping patients with thyroid nodules and thyroid cancer. We're also fortunate to work with a pediatric endocrinologist who's at Children's Hospital, which is only a 5-minute walk from our hospital. So this is really kind of a neat integrated team of endocrinologists. Endocrinologists will tell you that we're only as good really as the people that we're working with. And that really starts with our surgeons. And we, again, are very fortunate to have a group of 4 very high volume thyroid cancer surgeons who work at our institution, and they're really great to work with. We have a nuclear medicine team that is really fantastic to work with as well. And what we do with the nuclear medicine team is we have a joint meeting every month to go over the cases of patients coming up for radioiodine to make sure we're all on the same page. And this is really run by a nurse practitioner, Erin Meyerhoff, who works in our group and has gotten to know thyroid cancer very well. She also runs what's called our Thrive program, which is for patients who don't have any evidence of cancer anymore, but still need long-term care for either the side effects or sometimes maybe getting their thyroid hormone adjusted and figuring out other problems they may have. So we move people into this Thrive clinic with Erin once it looks like they're likely free of disease. We depend very heavily on radiology and interventional radiology. And again, we're fortunate to have 2 interventional radiologists who could do alcohol ablation. So it's just like doing a biopsy, but injecting the tumor usually in the neck with alcohol, but can also be in other tissues. And then radiofrequency ablation, another way to ablate these tumors. So you can do stuff short of surgery for some of these patients to help control their tumors. We have a great group of pathologists that really help us decide, is this anaplastic? Is this medullary? What type of thyroid cancer is this? We're getting a new advanced practice provider to have a joint multidisciplinary clinic between endocrinology and surgery where we real-time see these patients together. And this has been really working well at our cancer center and other areas, and they just launched it. We're just launching it in thyroid. A great team of medical oncologists. And again, that's going to be really the focus of my talk now, the interaction between the endocrinologist and the medical oncologist when we're considering some of these what are called systemic therapies. We have a great radiation oncologist who specifically works with us and our thyroid cancer patients. And very importantly, and related to these directed therapies, we have molecular pathology. And I think I already saw one of the first questions and answers even before we started was about doing mutational testing, and we'll talk a little bit about that. And then finally, we do a bunch of translational research too, to figure out new ways to help take care of these folks. So as you can see, it really takes a village. It takes a team of people to do this. And this is I'm fortunate to be working with this team here at the University of Colorado. And finally, you see all these red dots on people. This is part of the rapid anaplastic response team. Somebody comes to us with anaplastic thyroid cancer, and we get them usually to see somebody in each of these groups, one person in each of these groups within 48 hours. So we can make a plan because we know anaplastic thyroid cancer moves very quickly. So that's my shameless plug. And then, of course, we work with the International Thyroid Oncology Group to try to push the horizons forward with new studies. So I want to frame this around FDA-approved drugs for thyroid cancer. And as I just said earlier, the first really approved drug was radioactive iodine in 1971. It was approved by the Food and Drug Administration, even though it's been around since 1946. Most people don't know what the next drug that was approved for thyroid cancer and is actually a drug fairly soon after radioiodine called doxorubicin or adriamycin. And this is what's called a cytotoxic chemotherapy that's been used in many cancers, probably most commonly used now in breast cancer with other therapies, but is used in many cancers, really isn't used much at all in thyroid cancer anymore. Even though it was approved, it really didn't work very well. Part of the reason I'm going to show this on a timeline is I'll put in here what I consider the thyroid cancer therapeutic desert. There's a period of time here where really not much. We had surgery, we had thyroid hormone, we had radioiodine, and for those rare patients with advanced thyroid cancer that we couldn't use those, we could try this doxorubicin, which again didn't work very well. So really it started in the mid-1970s. I'm just kind of going by decade. 1980, we were in that desert. 1990, which is when I started taking care of patients with thyroid cancer over 30 years ago, I really entered in the middle of this kind of therapeutic desert. 2000, 10 years later, we're still in the desert. 2010, another 10 years later, we were still in the desert. It wasn't until 2013 when we had our first next FDA approved drug called sorafenib. And I'll mention that a little bit in the next slide. And then 2 years later, lenvatinib, which I think, again, those of you who are talking about these therapies probably know about this. I'll talk a little bit more about that. And then I just wanted to mention in the next talk that I give, I believe at 5:30 Eastern time, is I'm not going to talk about it here other than right now, is pembrolizumab is one of these checkpoint inhibitors. It's an antibody. And the reason I have it here in blue is it's approved for any solid tumor that has certain features. And I won't go into all those features now, but including thyroid cancer. So rarely we can use this in some of our thyroid cancer patients, but I'll talk about immune therapies in another talk that I have coming up. That was approved in 2017. I'll show this study with dabrafenib and trametinib for anaplastic thyroid cancer, because that was really a game changer for patients with anaplastic, a subset of patients with anaplastic thyroid cancer. I'll talk a little bit more about larotrectinib and entrectinib. They're called Ntrack inhibitors. They were approved in 2018 and 19. And then in 2020, just last year, 2 RET inhibitors were approved, selpercatinib and pralsetinib. And again, I'll talk about those a little bit more, but I wanted to give you that timeline to show you that we really had a period of time where we didn't have much new to offer patients. And this has really been an explosion. And I think it's going to keep going. We're going to keep seeing more and more drugs and drug combinations coming on. So, but before I talk about those specifics, what I thought I would do is give you an idea of my thought process. And I think a lot of my colleagues' thought processes are about how do we consider these therapies for these patients. So this is patients, again, with radioactive iodine refractory. That's what RAIR means. And then in this case, we're focusing mostly on differentiated thyroid cancer, but I'll talk a little bit on anaplastic. So the first question I ask when somebody does have disease, we know they have disease, is it progressive? Is it growing? And usually that's over a 6 to 12 month period, but that can be variable. Or is it symptomatic? Is it causing them problems? Cough, shortness of breath if it's in the lungs, pain if it's in other areas. So we're asking these questions if it's progressive or symptomatic. And the other thing I'll add here is also large versus small volume. And that again can be a little bit subjective, but we talk about that when I talk with my patients. If in fact the answer to this is no, it's not progressive, not bulky disease, not symptomatic, as many of you know, what we do is we say we're going to watch. We call that active surveillance. We're watching very carefully, depending upon a number of factors, how often we watch. We're using our chemotherapy TSH, because TSH can stimulate, especially differentiated thyroid cancer to grow. So we like to suppress that with thyroid hormone. And so we just stay in this loop as long as we can, because I have some people I've been following for 20, 25 years, and they've been doing very well in this loop. Some patients, though, move out of this loop. And so if they do have significantly progressive or bulky disease or symptomatic disease, I then ask the next question of, are there just a couple of spots, couple of lesions, couple of tumors? If it's just a few tumors, what we consider is what's called directed therapy, surgery, radiation therapy, these ablation therapies like alcohol ablation or radiofrequency ablation. We consider those types of therapies for just a few lesions, because if you put somebody on a systemic therapy for a long time, there are side effects. So we try to avoid that if we can in this instance. If in fact there are many spots, many lesions all over the body that we really can't treat with those directed therapies, that's when we consider systemic therapy. And obviously the first systemic therapies we want to consider are the ones that are FDA approved, the ones that I listed. They're for you. And in here, which I didn't have when I made this slide before, this is usually where kind of early on in here is where we'll do that mutation testing. And again, I'll talk a little bit more about the mutation testing. So we do the FDA approved therapies. We also consider adding bone protecting therapies that people like are used for osteoporosis. These are usually at higher levels, given more often to protect the bones from fracture. So if people have tumors in the bones, we'll consider those therapies as well. So what systemic therapies do we want to give? The FDA approved therapies. If these therapies can't be used or the person progresses on them, then we consider entry into a clinical trial. And we say, well, what clinical trial can we put a person in? If there's not a clinical trial that's available or appropriate, we then consider off-label therapy. But this is sort of the thought process that at least I talk with my patients about, and a lot of us go through with our patients on where do they fit here, instead of just jumping to one of these therapies. But we want to use them when we think that they'll be most helpful. So now the next slide I'm going to show you is actually a pretty complicated slide, but it tells you a bit about the thyroid cancer and why we use these drugs. So this in the middle here, this blue thing is a cancer cell. It's a thyroid cancer cell. And then these two other cells near it are representing what's called the microenvironment, other cells in that tumor tissue. Some cells are what are called endothelial cells that supply blood to the tumor area. Others are immune cells, and these are like these T lymphocytes, which again, I'll talk more about in my next talk. I really won't focus on that here. And then you can see on the outside of the cell, there are these receptors. All cells, what they tend to do is sense their environment through these receptors and then cause these signals to go down into the cell to tell it to do something, depending upon that external environment. And what we find in thyroid cancer is some of these on the outside get mutated in various ways, usually to be turned on all the time, even without an outside stimulus. And that's called an oncogene. And they can have oncogenes on the inside of the cell too that get mutated. And again, people know the most common one we talk about is BRAF. But you can have mutations in any way along this pathway. And you can see there are many drugs that actually can block these receptors. In some cases mutated, in some cases not. The two big ones that were first approved, sorafenib in 2013 and lenvatinib in 2015, are what are called multi-kinase inhibitors. And you can see it means they hit many of these. These are what are called receptor tyrosine kinases, the ones on the outside. They hit many of them. They don't just hit one. So they hit multiple receptors. That can be good for cancer treatment, but it also can be bad for side effects. And they have quite a few side effects. In many cases, we can adjust the dose or do other things to help mitigate that, but they have a lot of side effects. But these were these first level inhibitors, and you can see that they hit multiple pathways. That's why they're called multi-kinase inhibitors. So I just want to show you the one we use probably most commonly now of the multi-kinase inhibitors, and this is lenvatinib. It's also called Lenvima. And this was the study that basically got this approved by the FDA, published in 2015 in the New England Journal of Medicine. And this shows what's called progression-free survival. So 100% of the people up here at the start aren't having progression. So these are people either have progressive disease or die from their disease. And you can see 100% because everybody's entering in the trial. And then if we look at the placebo, so this means that they didn't get active drug, they got a pill, but they didn't get active drug, rapidly that falls down. People start, in the most case here, having progressive disease. Some people do die from their disease, but lenvatinib really slowed that. And this is one of the most impressive differences that I think I've seen in these drugs in almost any cancer. So it's really a game changer for people with differentiated thyroid cancer that couldn't be treated with radioactive iodine or other measures. So this really was a great advance, and we treat a lot of people with this drug. Downside is it does have side effects. People need to be on it usually lifelong if they can tolerate it. And then most people eventually, can be many years, but eventually progress. So this doesn't totally get rid of the cancer in a vast majority of people. So we sort of need other things that can maybe help decrease the side effects, be more specific in our therapies. And that's what the next generation now that you are seeing that were approved more in the 2018 to 2020 period. And again, coming back to this sort of pathway in the cancer cell, I put arrows on some other things. I'll talk about pembrolizumab. That's an immune drug at my next talk at 5:30 Eastern time. But I want to focus on these drugs here that can either bind this one receptor called RET or another receptor here called Ntrack. And these are, again, receptors that can stimulate the cancer growth. And now you see they're much more specific than lenvatinib or sorafenib in the way they hit their pathway. Also, there are some drugs for targets inside the cell called BRAF and MEK. This pathway, you may have heard, is called the MAP kinase pathway, RAS, BRAF, MEK, ERK. Again, a signaling pathway to tell the cancer to grow. What we found is that these types of drugs can block these either alone or in combination. And in theory, what they do is they slow the growth, which they do, I'll show you in some studies. But in the differentiated thyroid cancer, what they can also do is they can stop this from blocking iodine uptake. So remember I showed you that patient where we had no iodine uptake? now we get iodine uptake in a lot of times when we use some of these drugs, and I'll show you that at the end. So what about the genetics of these cancers? So people ask about getting the genetics tested, and this was one of the biggest studies done, led here at the University of Colorado, led by my colleague, Dr. Nikita Pozdeyev, and my medical oncology colleague, Dr. Dan Bowles. And what we did was we worked with a company, Foundation Medicine, and also took some publicly available data and put it all together for patients with advanced differentiated thyroid cancer and anaplastic thyroid cancer, and asked the question, what mutations do they have? And for purposes of this discussion, we had 468 samples from patients who had advanced papillary thyroid cancer. 3/4 of them had a BRAF mutation. Almost 10% had a RAS mutation in that MAP kinase pathway. 7% had what's called a rearrangement in RET. And then 1% each had these others. If we looked at the patients with anaplastic, and this was the biggest group of patients with anaplastic thyroid cancer to date, looked at 196, 40% had a BRAF mutation, so a little under half. 1/4 had a RAS mutation. And again, 1 to 2% had these RET, Ntrack, or ALK fusions. And that's just when instead of a point mutation in something in the DNA, it breaks the DNA apart and makes what's called a fusion protein. Why do I bring these up? Because they're druggable. And in people with BRAF, you can use BRAF inhibitors, that's a little I, or these MEK inhibitors, that little protein that's below BRAF, that signals below BRAF, or a combination of these. RAS, we're starting to think about using MEK inhibitors, but there's a lot of research that needs to be done in that area. The RET inhibitors I'll give you a little example on, and the Ntrack inhibitors I will as well. And I really won't talk about these ALK inhibitors because they're not approved for patients with thyroid cancer, but we do tend to use them if we do find the rare ALK mutation, because they are druggable and they work in other cancers, and we think they also work in thyroid cancer. So what do we do at the University of Colorado? We can send many different mutation testings, but we work with Dr. Dara Eisner in our molecular pathology core, and we first do a BRAF mutation on most people, especially papillary or anaplastic, and she can turn that around pretty quickly. And then if they have a BRAF mutation, we're kind of done, because if they have a BRAF mutation, they don't have a lot of these other things. But if they don't have a BRAF mutation, we check the other things to see if we can find something that is druggable. So that's how we now use our mutation knowledge to say, can I use one of these very specific drugs? If they don't have any of these mutations, that's when we can use something like lenvatinib or sorafenib, or consider other things in these patients. So that's how we sort of do it. Other places do it slightly differently. I think over the next 10 years, we're going to harmonize better across institutions and hospitals and things about how we do it. But right now, there's many different ways it's done. So I didn't know, Patty or Jody, if there are any questions up until now, because now I'll talk about the specific therapies.
Yeah, there have been about 5 questions up now. If you want to look at them now, or wait until you've gone through these.
Yeah, because some of them, we have a whole thing about a patient. Yeah, so here's one. I recently read an article regarding targeted therapy. Tumor cells are removed from the patient. The cells are given a drug to compromise the cells, then they are reintroduced back into the patient to help the body recognize and destroy the tumor cells. Is this happening with your research? Our research isn't doing it specifically. A lot of this, what this person's asking about, is more in the realm of that immune therapy, and I will be talking about that at 5:30 in my next session. A lot of that is where you take some of the cells from the patient and do some manipulations and put them back in, and it's usually to help the immune system go after the tumor. Is it warranted to repeat genomic testing after years of multiple tyrosine kinase inhibitors on a poorly differentiated patient who has multiple mutations on MSK impact? That's the Memorial Sloan Kettering test. And then patients currently getting these therapies. Again, questions are getting pretty specific, but in general, what I'll say is that if it's been years since somebody's been tested, it probably isn't a bad idea to consider retesting, because some of the older tests maybe didn't cover as many things as the newer tests do. If it's been really recently that someone's been tested in something like the MSK impact, or some of these other big companies that do this, probably doesn't do a lot to repeat that. Now, if they did it on the primary tumor, and let's say somebody now years later had a metastasis come up, sometimes what people will do is biopsy the metastasis because something could have changed over that period of time. But I wouldn't repeat it on the same tumor. A question about cabozantinib being a good therapy for patients treated with for poorly differentiated thyroid cancer. And there is a recent study that shows that cabozantinib actually is pretty effective in as what's called a second-line therapy, patients who've progressed on something like lenvatinib or sorafenib. So we do now consider cabozantinib in those patients as what we call a second-line therapy. It hasn't yet been approved for that I know of, but I wouldn't doubt it's not going to be approved in the near future. Did our study identify mutations in poorly differentiated thyroid cancer patients? Some of these patients may have had poorly differentiated thyroid cancer. What I would say is, interesting thing about that is pathologists disagree to somewhat on what they call poorly differentiated. So there's a spectrum. And what I said, advanced papillary thyroid cancers, some of those behave like poorly differentiated. They may not be fully defined as poorly differentiated. So there is a bit of an overlap between advanced papillary or follicular thyroid cancer and poorly differentiated thyroid cancer. It's a bit of a semantic description at times. So these are all kind of patients with advanced cancer. If you have BRAF mutation, is there any of the new drugs that can be used after lenvatinib stops working? Well, generally, if lenvatinib stops working, we could consider sorafenib for those patients. Some people who don't respond to lenvatinib will respond to sorafenib. But now the next level drugs we're thinking about aren't yet approved in differentiated thyroid cancer, but we do consider using a BRAF and or a MEK inhibitor in these. As this study I have up here, dabrafenib is a BRAF inhibitor and trametinib is a MEK inhibitor. So we do consider those, but that is off label at this point for differentiated thyroid cancer, not yet approved. What happens after you've had progression after targeted therapy? Again, we consider other targeted therapies in these patients, or maybe a combination of targeted therapies and some of those directed therapies. The question was, what is the average survival? That's pretty hard to say in any one given patient. Obviously, the survival drops. But it's hard to say from that question. It depends on where the tumor is, how much tumor somebody has, how they're doing. How someone's what's called performance status does make a big difference in survival as well. So I'll come back to some of these questions, but I'll move forward with talking about the specific inhibitors and how we now use them. This study is the study that actually got these drugs approved for patients with anaplastic thyroid cancer. Dabrafenib, which inhibits that BRAF, and trametinib, which inhibits that next in the signaling pathway MEK. So you're sort of hitting that pathway really hard with both drugs. This is patients with anaplastic thyroid cancer. So one thing, again, I don't know how much many of you have seen this. This is called a waterfall plot. Each of these bars is an individual patient. Amazingly, in this study, there were only 16 patients. And usually you have many, many patients in studies, only 16 patients. But really, this is, if you look above the line, it's tumor growth from when you start them on the therapies. If you look below the line, it's tumor shrinkage. And you can see all the way out here, this blue one called a complete response. The tumor shrank to where they couldn't measure it anymore. This is anaplastic thyroid cancer. So really, there were some pretty impressive responses with these two drugs. The other thing, and I'll show a couple of different slides with these, is I think this is very helpful to look at it as well. So not only how much does the tumor shrink, but kind of in a way, how does that individual patient benefit? So what this is this is called a swim plot or a swim lane plot. Again, each bar is an individual patient. They usually put on the top the patient who's responding the best, because it's time on the bottom, how long they're on medicine. And obviously, if they're still on medicine, they're tolerating it and they're deriving a benefit. And the little arrows here mean they're still on, when they wrote the paper, the patient was still on study. And as you can see here, in weeks, we're now out into the range of 2 years in some of these patients. Anaplastic thyroid cancer. So some of these patients do really well. Many of them actually do quite well. Some don't respond as well, and we'll keep working to see if we can get a better handle up front of who does and who doesn't respond so well. But this is what got these two drugs approved for patients with anaplastic thyroid cancer that has that BRAF mutation. that 40% I showed you in our study of the anaplastic thyroid cancer patients. So 40% of people could get a benefit. And we immediately check that in every anaplastic thyroid cancer patient and consider this therapy if they have a BRAF mutation. So the next one I want to talk about is one of those newer ones. Again, that's more of a focused inhibitor, not a multi-kinase inhibitor, called percatinib. And that goes after this RET gene. And this, again, this big study published in 2020 by my colleague, Dr. Lori Worth and her colleagues, showed really some pretty impressive responses just by blocking this pathway, which I kind of call the gas pedal of the cancer. And again, this waterfall plot shows that most individuals responded quite well. And many of them had been pre-treated with those multi-kinase inhibitors for medullary thyroid cancer, vandetanib and cabozantinib, and some even on both. They still responded very well to percatinib. And really, the side effect profile is much better. It still has side effects that have to be managed, but it's much less side effects with these very specific drugs than from the multi-kinase inhibitors. And this just shows people who have usually papillary thyroid cancer or follicular thyroid cancer, so non-medullary. And instead of a point mutation, they have what's called that rearrangement, the breaking of the DNA and coming back together. And again, had a very good response in these patients. And a few had anaplastic thyroid cancer, poorly differentiated, as one of the questions was, papillary, and even a Hürthle cell thyroid cancer. So we can use it for a lot of those, and it's now approved. So another reason that we want to get these mutation testing early in our patients. And then I'll just show you an example of those Ntrack I showed you that's rearranged in some of these cancers. And this is in patients who had all sorts of cancers. And two of my colleagues at the University of Colorado were involved in this study. And you can see many different tumors, but here in light green is the patients with thyroid tumors. So I'll just point them out here, 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 and here. So there are 5 patients with thyroid cancer. And you see really some good to great responses. So we want to look and see if they have these, even though it's only about 1% of these people, of people with radioiodine refractory thyroid cancer are going to have these mutations. It's worth checking because these therapies are very targeted and really quite well tolerated. So that's kind of direct therapy. So what's kind of coming on the near horizon and the farther horizon? I think what's really been exciting in our field is that we can also use these to maybe coax the tumors to take up radioiodine again, called redifferentiation. And really one of the first studies that was published back in 2013 by Alan Ho and colleagues at Memorial looked at a drug called selumetinib. And what that does is that hits that MEK, kind of farther downstream from BRAF. And it's not a super strong MEK inhibitor, but impressively what they did was tested with radioactive iodine, and they showed that they really didn't have much uptake. Then they treated them with selumetinib for 4 weeks. It's a pill that they give them, and then relooked to see, do they take up radioactive iodine? If they did, then they treated them with radioactive iodine. And this just shows one patient who on the left here at baseline had a bunch of lung tumors, but you just don't see really any uptake of that radioactive iodine. Whereas after they got treated, now you see the uptake. And this is just what's called a fusion image with the CAT scan, all these spots in the lungs. Now you see lots more spots. So it looks like it can coax the tumors to take back up the radioactive iodine, and they do get some response after they get treated with radioactive iodine. What I'll tell you is this is not yet approved for this type of therapy, but we and others are testing single and combination of probably more potent drugs against that MAP kinase pathway that we think can probably do a better job of coaxing them to take up radioactive iodine. And in some patients, we may be able to again use radioactive iodine to treat the tumor. And then this just shows one of the Ntrack inhibitors. So it's not just the MAP kinase pathway. This is someone who actually was, again, before they got treated with that Ntrack inhibitor called larotrectinib, which is approved for advanced thyroid cancer, but not approved for coaxing them to retake up radioactive iodine. Don't see anything here, but now see uptake in the lungs with radioactive iodine. So then we can treat them and derive, again, a benefit. And this just, again, shows on that what's called fusion image. You see that there's no uptake, and this yellow stuff is all uptake of radioactive iodine in these. So we can use not only the MAP kinase inhibitors, but maybe these Ntrack and even RET inhibitors to coax them to take up radioactive iodine. So the last thing that I want to show you is a topic called neoadjuvant therapy. So what the heck is that? Adjuvant therapy, I think, is, if you've had your doctors talk to you about this, means, okay, we've done surgery, we think we got it all, but you have a high risk of getting cancer again. Let's give you radioactive iodine to decrease that chance of it coming back. That's called adjuvant therapy, trying to help keep it from coming back. Neoadjuvant therapy is treating somebody before you even do their definitive, like surgery or therapy like that. You're doing a treatment to make the surgery safer and more effective. And I just wanted to show you this really interesting study from MD Anderson Cancer Center. This is patients now back again with anaplastic thyroid cancer, but we can do it for different ones. If where they present with a really extensive tumor in the neck, that the surgery is going to be difficult, may not be safe, and may not get all the tumor out, we can first treat them with drugs. So these are patients with anaplastic thyroid cancer, BRAF mutations, who got that combination therapy I told you, dabrafenib plus trametinib, BRAF plus MEK inhibitor, and just shows you each patient. Patient number one here, the brain, this is the brain sort of taken up. This is what's called FDG PET. It's a glucose scan. The brain's supposed to take it up, but all this here is tumor in their neck, massive tumor in the neck that just no excellent surgeon could take all that out. And now after they've been treated for 3 months with that combination, much smaller tumor that now probably can more easily and safely be removed. And this just again shows another example, big tumor, really almost shrunk away. Big tumor, much less. So you just see that example. So this is a way we can treat people before we do their hopefully definitive surgery in some of these patients. So this is really a neat horizon idea that now many studies are being started to try to treat people even before surgery. So what I'll do is I'll leave you with this kind of, again, how do we think about when we see somebody who we can't give them radioactive iodine and they do have measurable disease, that can it be treated with directed therapy? Do we have to go to systemic therapy? Could we do active surveillance in these people? And how do we walk through the different therapies we can do? The future really is this redifferentiation therapy, maybe to put radioactive iodine back in the mix, neoadjuvant therapies to help prepare patients better for a more definitive and safer surgery, and then finally novel combination therapies that we and others are doing research on to try to not only slow tumor growth, but actually kill the tumor so somebody can get completely cured. That's really what our hope is in the future. So I just wanted to acknowledge again the Thyroid Cancer Survivors Association, my thyroid tumor team at the University of Colorado here, and this is all the folks that we work with to really help take care of these patients. And what I'll do is go back to this slide, and then I'll try to come back to your questions. So this first one I kind of didn't, because it was a 36-year-old male, recurrent radioiodine resistant papillary thyroid cancer. Is there a way to become radioactive iodine again, avid again, considering don't have specific thyroid cancer mutations as per somatic tumor testing report? So if you don't have those specific mutations, we really don't have a good way to do that. We tried, I did this too, 25, 30 years ago, many other things. There may be other therapies in the future, but there are ways off in the future. This person said that the mutation tumor burden was high at 22 mutations per megabase. Now, this again, I'll talk a little bit more about in my talk on immunotherapies, but there is an immunotherapy called pembrolizumab that's approved for patients who have any cancer, not just thyroid cancer, solid tumor cancer, who has a mutation burden above 10 mutations per megabase. Megabase is 1 million bases that you look at on the in the DNA. So that is one possible therapy for somebody who doesn't have these others that you can redifferentiate, but this would be approved as well. This is FDA approved. What are the side effects of BRAF and MEK drugs for papillary thyroid cancer? A lot of them are the standard ones that we see, which, there we go, standard ones that we see, which they can be fatigue, diarrhea, rash, effect on white cells. One unique thing we do see with these therapies is fever with these specific BRAF and MEK inhibitors. And some people can have super high fevers that we have to manage in these folks, can feel really, really bad and have very high fevers. And there can be some bleeding problems that this person had asked about, bleeding problems. Not as common, definitely not as common as with the lenvatinib or sorafenib, or for medullary thyroid cancer patients, the vandetanib and cabozantinib, because they hit that VEGF receptor, which is in the blood vessels, that really works on blood vessels and bleeding. That's the way it kind of treats the tumor, but also can lead to bleeding and clotting. So it's kind of a worse risk with the multikinase inhibitors, but with any of these therapies can be a risk. When drugs target a mutation like BRAF, the V600E, that's the most common mutation seen, does it also target the wild gene? Very good question. The ones that we used originally, like sorafenib, some of those really do target the wild type gene. The more, as we're getting more and more specific, they less and less target, but there is always some effect on the wild type gene that we can see, but these are getting more and more specific for the mutated gene as we kind of get second and third generation BRAF inhibitors. How do you test micrometastases in the lungs for genetic change? 1 centimeter or less, but thyroglobulin doubling time is rapid and the radioiodine resistant. Yeah, so that's a bit of a challenge. You can send a surgeon in to take a piece of lung tissue and get some of that tumor. That's a big procedure. The other thing that's evolving is what's called liquid biopsies. So some places, and this is getting more common now, it's not as common as testing the tumor itself, but you can draw some blood, and in that blood, they're going to be circulating tumor cells, and there are ways to look for those mutations in those circulating tumor cells. So in a patient where we can't get tissue, sometime what we'll do is we'll do that liquid biopsy of just doing a blood test to try to see if we can tell if that mutation is in the cancer cells in the bloodstream. Since these therapies have been introduced so late, can you speak to how it will change survival rate long-term? That's a very good question. And I think we have to continue to work on that. There is some evidence, even with lenvatinib, in certain subgroups of people, they do improve survival. But I think we have to just do longer studies. And one advantage in a way of that is many patients, even in a study that I'll be talking about that we did with the immune therapies, even when they have advanced cancer needing these therapies, a lot of people still survive really a relatively long time. And so it takes a longer to get that overall survival data. It's just going to take a while to get it. I think it will have an impact on overall survival, but we just have to kind of have more time to get that data. What about improvement of side effects over time for lenvatinib? And what is the longest people are tolerating lenvatinib without progression? Two very good questions. So improvement of side effects over time, I think I've seen that with most all of these drugs that we use. So if somebody has some mild to moderate symptoms and they say to me, let's keep this dose going, I think I can tolerate this, and we think it's safe for them to do it, I tend to see over time those do get better. But sometimes they need a dose reduction to get better. And again, when you do a dose reduction, it doesn't mean that you're treating the tumor a lot less. You still can have a good tumor effect. And we've seen that with some of these drugs.
How long do people tolerate it?
Oh, yeah. How long can people sort of be on these? We have people at our institution who probably are on it somewhere between 5 to 10 years. And they're getting on a dose that they can tolerate, and it's controlling the disease. Like I said, eventually, probably most everyone, it's going to grow. But you can buy some good quality time. Some of these people, if we can get the dose right so their side effects are tolerable and they're doing okay. I've had people who've gone, traveling, doing all sorts of other stuff on these medications. And for up to 5 to 10 years so far, that's partly because that's about the limit of how long we've really had experience with these drugs. Yeah, are there any targeted therapies for Hürthle cell lesion with a P10 deletion? Boy, that's a good and tough question. Again, and probably this person who wrote it knows that these Hürthle cell tumors are very different. I showed you all those pathways. Those are mostly for papillary and follicular tumors. Hürthle tumors are a real different beast. What they have is a bunch of chromosome abnormalities where they're either missing whole pieces of chromosome or have duplications of whole pieces of chromosomes. And so far, we have not found good therapies for those folks. We thought one of the best therapies would be targeting that second pathway I didn't talk about much, called the PI3 kinase pathway. The drugs are called mTOR inhibitors, such as everolimus, but we haven't had really super positive responses yet, because these are, again, these tumors seem to prefer sugar, I guess, for lack of a better term. And we thought these would be good therapies. The thing I will say is our International Thyroid Oncology Group is actually bringing together a bunch of people who are very interested in studying and caring for these patients with Hürthle cell tumors. And we're hoping, putting those smart heads together, we can start making some headway with Hürthle cell tumors. But unfortunately, these really targeted things aren't so good. That said, they do respond to things like lenvatinib or sorafenib. Does it make sense to pursue these therapies if a patient has anaplastic thyroid cancer, but currently has no evidence of disease 1 year after surgery, chemo, and radiation? Could any of them keep the disease from returning rather than getting rid of what is already there, i.e. shrinking the tumor? Yeah, again, a good question, because the problem with anaplastic is we don't have a good tumor marker, blood marker like thyroglobulin or calcitonin. We can only look mainly for tumor by CAT scans, PET scans, a bunch of imaging that we do. I think if somebody, we do have some patients who get a complete response to surgery, some chemotherapy, radiation, and I've followed some patients too, long-term, who really have not had it come back. So I think most of my colleagues would agree. I'd probably lean a little more on my medical oncology colleagues on this, but probably at this point, since we don't have evidence, we wouldn't automatically start somebody like this on these drugs in hope of keeping it away, because we don't know if we're doing a benefit. We're putting them on these drugs, expensive drugs, usually the 2 drugs that do have side effects, and we don't know if we're doing them a benefit. So most likely at this point in time, what we would do is watch very carefully, and if we see something growing back, we may biopsy to make sure it's what we think it is, and then is when we put them on these medications rather than treat them preemptively, sort of as an adjuvant therapy. If taking, for example, larotrectinib as primary therapy for Ntrack gene fusion cancer, how is thyroglobulin affected, and does a rise in thyroglobulin on therapy mean anything? Yeah, usually with most of these therapies, if you're getting a good response, the tumor marker does go down as well. And it's pretty well matched, I think, with the tumor with a lot of these therapies. Interestingly, with actually in medullary cancer, with the RET inhibitors, the RET can actually decrease the cell from making calcitonin. So in some patients, you can really just bottom out the calcitonin, but it maybe doesn't affect the tumor as much. So you need to look at both. But with the Ntrack inhibitors, since they're really not involved in a lot of making of the tumor marker, it probably is a good indication of how you're affecting the tumor. Can neoadjuvant therapy be used to determine procedures for distant mets, i.e. the lungs? Well, I guess in theory it can. Anytime the neoadjuvant usually means you're going to do another therapy then, and the most common therapy we do is surgery. So let's say in somebody, if they had, some big old tumor in the lung that you wanted to remove, but it was invading things and the surgeon felt it wouldn't be a safe surgery and they wouldn't be able to get it all, you might put somebody on one of these therapies. And if it shrinks it enough where then they feel they can safely remove it, they may go in and remove it. That's how I could see that being used, but not for widespread lung metastases. It wouldn't really be a neoadjuvant therapy because you probably wouldn't follow it up with something like surgery. What is a wild type gene? Good question. That basically is the normal gene. So that's what we look at, like BRAF. We need it for signaling in cells to tell them when to grow, when not to grow. And the wild type gene is just the normal gene that doesn't have any known mutations that can kind of cause a cancer. The other thing I'll say on this is there are things called polymorphisms, and that just means different DNA, different AGTC at that DNA in different people. It's not necessarily a mutation that causes something, but it just says, well, how we're different. That's a polymorphism. A mutation usually means something that's going to change that protein and have the protein work differently. So wild type just means the normal gene. Is there ever a case where you would use one of these therapies before treating with radioactive iodine, or is it always the last option to treat with? Yeah, again, a great question. I think right now the standard of care is to use them as later therapies in people who don't respond well to radioiodine. My prediction, we're starting to do it in some people now, but higher risk people, is what we'll probably be doing is using these things up front so we can get more radioactive iodine in up front to do better therapy. It just hasn't been yet as well studied. There are studies going on, and I predict in the future, 5-10 years from now, maybe 5, that we may be using these more commonly to help aid the radioactive iodine up front and not wait until somebody is refractory to radioiodine. But we need to study it better to say who would it benefit and what are the potential harms. Do you start folks on highest dose of lenvatinib? Very good question. The starting dose of lenvatinib is 24 milligrams. And I generally, with my medical oncologist, we start people on 20 to 24 milligrams. Now that said, if you have a very small person who's much older, in their 80s, we'll probably start on a lower dose, 10 to 14 milligrams. That's a little bit more just the art of medicine in doing that. What I'll tell you is there are some people who believe in the kind of bottom-up theory where they start you on a low dose, and if you tolerate it, they just slowly move it up until you kind of find your highest dose. Many people, us included, start people on as high a dose as we think they can tolerate, and then just are really careful and follow them very closely with our nurses and back off until we get the right dose. Because some people tolerate 24 or 20 milligrams. And then we're getting hopefully our best effect on the tumor. Do you ever try 2 weeks on, 1 week off with lenvatinib? No, that's again a good question. That's how pazopanib, another drug, is used. Weeks on and weeks off. I have not done that myself. When I go to meetings, I don't talk to a lot of people who are doing that, but maybe some people are trying it. It's not an unreasonable thought. You can kind of think there's all sorts of combinations that people could probably think about and do. The problem is setting up a really good study, getting the study paid for, and doing these studies in people to make sure that it's kind of safe to do and, you know, doesn't allow for some sort of breakthrough of the tumor. But, you know, we obviously do that every day in our practice in a way of you'll put somebody on, and if they get bad side effects like that grade 3 or 4, the really kind of worst side effects, we'll stop it. Or somebody's going to surgery, we've stopped it. So we do have kind of a little bit of experience of stopping it. And for short periods of time, it's pretty good. But many people, if you do stop it, say because they can't tolerate it, you usually do see tumor progression when you stop it. Do these drugs affect a person with kidney disease caused by an immune response such as IgA neuropathy? Yeah, they can, depending upon your both liver function and kidney function. These drugs, we have to be very careful how we use them, and there are ways that we then dose depending upon the drug and how it's what's called eliminated, either through the liver or the kidney. Interesting, the IgA nephropathy is because that's kind of an immune response. And like I said, I'll be talking in a bit about immune drugs. That's where I would be a little bit more worried about the immune drugs in somebody who already has an immune problem in those, but we can usually modify the drug doses for people with kidney being affected or liver being affected. Someone has an ETV Ntrack 3 positive fusion, breast, thyroid, and melanoma cancers, surgery, 67, get follow-ups, no known progression on papillary after 4 years. Addition of a liquid biopsy be appropriate as part of my follow-up. Again, yeah, very good question. If when you say no known progression, if the person means you can't measure the tumor marker thyroglobulin and nothing is measurable on CAT scan or ultrasound or any imaging you do, that's called excellent response to therapy. You don't need to do that blood test for 2 reasons. One, because we're probably not going to do anything at this point with that information. And more importantly, is if we see no evidence of disease by thyroglobulin or imaging, you probably won't measure the cells in the blood. There are too few cells, if any, in the blood. So you probably wouldn't see the cells in the blood. But if there are tumors that are still measurable, if they're tiny and staying the same, you could do a blood test. Again, I wouldn't be ready to consider giving therapy to somebody who has very small volume, stable disease that has no symptoms. So you could wait as well. Name of the possible drug for someone who is RAI resistant and shows no mutations. No mutations, who's RI. Oh, it might have been the person who had what's called that high tumor mutation burden. And that doesn't help take up radioiodine. That's that immune drug called pembrolizumab, if a person has a high tumor mutation burden. And many of the tests will look at that.
Okay, Dr. Haugen, someone did mention in the chat that they are receiving Lenvima every 2 weeks with 1 week off.
Okay.
Just an FYI that someone mentioned that.
Yeah, no, I think that's interesting. I mean, like I said, I don't know of any studies that have systematically studied that versus being on lenvatinib all by itself. So it's kind of an off-label indication. But hey, the other thing is for that person, if it works, especially with getting the holiday and feeling a bit better, kind of an interesting way to approach it.
Okay, we have about 3 minutes.
So do you want to just wrap up, or should we, do you want to, it looks like there's still plenty of questions. What would you like to do, Patty?
Do what you can in the next 3 minutes, and
Okay.
we can hang a little bit later, but let's let people know that we can't take any additional questions.
Okay.
We'll try to clear up what's already here.
All right. How does thyroid cancer lay dormant for so many years? 35 years ago, radioactive iodine cancer came back in my lungs 5 years ago, so 30 years later. Boy, I would like to know that. We're actually doing studies in that area. That's what's called tumor dormancy, and that's a whole field of research. And thyroid, I think, is a perfect one to study because I follow many patients who have tiny little lung nodules that don't move for decades. So we don't have a good answer for that right now, but it's a very good question. And it's something that we and others are studying. Neoadjuvant with percatinib 3 months prior to medullary surgery. Think it saved my life. Starting to get some side effects. So looking at dose reduction, see if that helps. Is that something that would affect tumor reduction in metastases? Yeah, again, I think we tend to, if you can't tolerate the side effects, we tend to reduce the dose, and people still tend to respond quite well with that. You do get to a certain point, if you have to get such a low dose, you'll see the tumor starting to progress. But usually those first few dose reductions, people still get a good response in the tumors. So I would go with the dose reduction if you're having bad enough side effects. Patients had their original surgeries before genetic testing with standard active surveillance. Oops. Would you advise them to get medical mutation testing prior to disease progression? Yeah, again, that's that question though. If you don't have much disease and you can't get tumor to measure it, or you have very small volume tumor that isn't doing much, that blood test may not help you, the liquid biopsy. So I would just kind of sit tight and watch. And if it did look like it was progressing, you could either biopsy a tumor or get a liquid biopsy at that time, because it may never progress. Describing the typical way pazopanib, weeks on and weeks off. And here's where I just haven't used pazopanib in a while, and we've had so many other drugs that we've been using. I think it's either 2 weeks on and 2 weeks off, or 4 weeks on and 2 weeks off. And I don't have it right off the top of my head. What is the current status of treating an Ntrack ETV6 fusion? Again, we could consider an Ntrack inhibitor in somebody, especially again, who has progressive disease. Oh, do insurance companies pay for liquid biopsies? Good question. Not always. So and sometimes even mutation testing on tumors from tissue blocks. So that's something that usually kind of has to be worked out with the insurance company. P10 mutation, yes or no on everolimus? Can't really tell you. Some people try it, but the studies aren't really that helpful. And the last question, larotrectinib. What is the lowest dose you'd recommend? Is there any harm in taking a lower dose? You always can reduce the dose. I don't have, and I'd have to probably consult some of my medical oncologists to see what is the lowest dose that would be best used. So I don't have a perfect answer for you. And I think Patty will stop there.
Thank you so much, Dr. Haugen. So appreciate all the information and everything, all the questions that you were able to answer in such a short period of time. I think a lot of people will be attending your next session.
Great.
Definitely. I put the session number in the chat.
Great.
Okay.
Yeah.
Well, thank you both very much, and thanks for moderating the session.
Okay, well, thank you. I hope to hear more in the future about liquid biopsy. I just did an in-service on it, and it's fascinating.
Yep, I think it's going to become more and more common. There's some hurdles that need to be gotten over to make it really efficient and effective, but they're getting there. People who are doing it are getting there.
Yeah. Okay. Well, thank
All right.
you. See you in 30 minutes.
Take care.
Okay.